Okay, okay. You're not seeing my picture, no?
No, 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 sir.
How to do it?
Sir, in this video options,
Huh.
there is a choose virtual background. Uh,
1 second, sir. I'm not able to find.
Sir,
Hello?
in the yes, sir. Sir, in the video setting option, I mean, in the down part, you have this mic and video
Yes, stop
icon.
video. Yeah, yeah.
Yeah,
Okay.
in that, when you click on the just beside up
Uh,
arrow,
Okay, okay.
yeah, in up arrow you have options. Yes,
Huh.
there choose virtual background.
Yeah, yeah. Then it came. I
Yes,
should.
sir.
Uh,
Click on none. Click on none, sir.
okay, okay. Okay, sir.
Yeah, thank you, sir. Thank you very much.
Thank you.
So, with your permission, shall we start, sir?
Sure, sir. Sure, sure.
Yeah, thank you, sir. Good evening, doctors. I'm Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I kindly request all the participants to post their questions in the comment box, and at the end of the talk, we will have a short Q&A session. And good evening, Dr. Ambrish, sir.
Good
Thank you
evening.
for joining us today, and thank you for giving us your valuable time, sir. It's my honor to introduce Dr. Ambrish, sir. Uh, Sir done her he's MD, DGO, and FICOG, and he's a consultant obs and gynecologist at Mysore. And he was a former professor and HOD at the Department of OBG, JSS Medical College, Mysore, and he was a past president of KCOGA 2015, and he was the organizing chairman of KCOGA conference Mysore. And coming to the his field of interest, GDM and HDP, and coming to the he is a master trainer in PPI UCD GDM. And thank you, sir. uh, and today we know that uh, there are controversies in GDM management, and in a pregnancy complicated by gestational diabetes mellitus, there should be excellent glucose control and as a foundational as appropriate weight gain and adequate nutrient intake according to the guidelines. So now, without wasting much time, I turn over the time to Dr. Ambrish, sir, to talk on recent guidelines in the management of GDM. Over to you, sir.
Thank you. I should go for the side share screen.
Yes, sir.
Am I audible?
Yes, sir.
Yeah. Good evening, friends. I'm happy to be here once again. At the outset, I would like to thank the Shield for giving me this opportunity to talk to you. Diabetes is one of the medical disorders complicating pregnancy these days, apart from hypertension and cardiovascular disease. We will see the recent guidelines, what it tells. slide is not moving.
Sir, you please click on the slide, sir.
Okay, fine. As I said, gestational diabetes is one of the most common medical conditions we are encountering in a day-to-day practice. It's a broad term. Diabetes is a broad term which says that there is some amount of glucose dysregulation. Coming to the prevalence, global prevalence, GDM is common worldwide. But comparatively in the western part of the globe, the incidence and prevalence is less. In Asian countries and the Eastern countries, actually, the incidence is more. Especially Indian ethnic origin women, though they stay in America or somewhere else also, they develop diabetes rather than compared to Caucasian women. So gestational diabetes is the insulin resistance due to the placental secretions and these slides are different. Something wrong has gone. Yeah. Sorry for that slide. So hyperglycemia in pregnancy could be diabetes in pregnancy or it's a gestational diabetes. What do you mean by diabetes in pregnancy? This is diagnosis done before pregnancy, whereas gestational diabetes occurs during pregnancy. There are type 1 and type 2 diabetes, which can be a part of the pregnancy. What is diabetes in pregnancy? It is hyperglycemia detected prior to the onset of pregnancy or hyperglycemia first detected anytime during pregnancy, and it meets the criteria for the diagnosis of the non-pregnant state as the WHO definition. What is the WHO criteria for diagnosis of diabetes in a non-pregnant state? We should remember non-pregnant state. Fasting blood sugar should be 126 milligrams per deciliter and 2 hour 75 grams glucose should be more than 200 milligrams per deciliter, or random plasma glucose of more than 200 milligrams per deciliter associated with signs and symptoms of diabetes. If this is the sugar values, then we say it is diabetes. What is gestational diabetes then? How it differs from the diabetes definition which I said now. So it's a hyperglycemia first detected in pregnancy during routine testing what we do. There will not be a previous history of diabetes and it doesn't meet the criteria of over diabetes. What I said in the previous slides of 126 fasting, postprandial 200 and random 200. It doesn't meet that criteria. And it often occurs between 24 and 28 weeks of pregnancy. So the prevalence of diabetes as per the latest International Diabetes Federation, 2019, it says that 1 in 6 live births is affected by hyperglycemia in pregnancy, out of which 84% have gestational diabetes. That means the prevalence of diabetes, GDM, is almost 84%. That means 1 in 6 live births is affected with GDM. Just see this chart where India comes. India, the prevalence of India is around, see the color you can make, it's equal to or more than 20%. Coming to the Asian prevalence. Prevalence of GDM in Asia is found to be very high when compared to European countries. The overall mean prevalence is around 11.5%. Highest in Taiwan, followed by Hong Kong, then Saudi Arabia, that lowest in Nepal and followed by Japan. South Asians have greater odds of developing GDM than others. It may be due to the maternal age, BMI discrepancies, as well as most commonly or most important is the ethnic background. It could be due to the genetic predisposition of the Asians to have higher risk of insulin resistance when compared to Caucasians. So that's why the higher prevalence of type 2 diabetes seen in Asia when compared to Europe. What about Indian scenario? Here also the prevalence ranges between 4 and 18%. In urban areas, the prevalence is more compared to the rural areas. You can see in this slide, there is Mysore. So this is the study we did in JSS Medical College 10 years back. So in and around Mysore, the population, the incidence of GDM is 9.5%. Whereas neighboring state, Tamil Nadu, it's almost 17.9%. So it's more. So there are genetic predispositions and then non-genetic factors like maternal age, obesity, diet, and lifestyle. The incidence of GDM is expected to increase every year. It's increased by 20%. That is, 1 in every 5 pregnant women is likely to have GDM. Imagine the burden. So there are few risk factors for GDM. One is modifiable risk factors and non-modifiable risk factors. So modifiable risk factors include overweight, obesity, and pre-pregnancy body mass index, metabolic syndrome and nutritional diet, polycystic ovarian syndrome, preeclampsia, and use of antidepressant and psychotropic medications, smoking, and poor sleep hygiene. Non-modifiable risk factors include maternal age, gravida and parity, and then ethnicity. And then there is a genetic and family history of hyperglycemia also is one of the risk factors. That means any family member has got a diabetes, the woman is likely to get diabetes in pregnancy more often. What is the impact of GDM? Why we should know about GDM? So GDM has got to impact both on this present pregnancy and also subsequent pregnancy. There is a high chance of recurrence in the next pregnancy. So it's almost, you can say, 41%. And there's a long-term maternal effect also. You can see the gestational diabetes women are associated with higher risk of disorders of glucose metabolism during long-term follow-up of pregnancy. And they are more prone to develop metabolic syndrome. You know, metabolic syndrome is nowadays one of the most common medical disorders. So 1/3 of the women of GDM will go into metabolic syndrome. What about type 2 diabetes? These gestational diabetes women are at a higher risk of developing type 2 diabetes when compared to normoglycemic pregnancies. And they are more prone for cardiovascular disease also. During a follow-up study of more than 10 years, patients with GDM had higher rates of cardiovascular morbidity, including non-invasive cardiac diagnostic procedures. What about the infants born to the GDM mothers? Exposure to diabetic environment in utero is associated with increased incidence of impaired glucose tolerance and a defective insulin secretory response in the adults. When they become adults, these people will have all these problems. And they're also more prone for diabetes, type 2 diabetes. As early as 20 to 24 years only, these infants born to diabetic mother will develop type 2 diabetes. About 45% of them develop type 2 diabetes. and they are more prone for obesity. And that's a vicious cycle. A woman with a GDM will give rise to infant with a GDM, baby with a diabetic prone, and then she is very high risk for the future life. In 2019, you can say the India, the population, 77 millions of people are diabetic, whereas in another 10 years, we are reaching 101 million. Even among the children and adolescents also, they are becoming more obese and then they are almost overweight. You can just see how it is doubling. So way back in 2000, it was 8%. Now it is almost 25%. Now we have to screen the patients for diabetes. There are multiple protocols are there. You don't know which one to follow. So all the global health organizations have advocated plenty of diverse algorithms for screening of and diagnosis of GDM. So these recommendations for GDM were criticized for lack of validation in the developed countries, the data, the results of the expert opinion. There were so many complications or misunderstandings were there. So the HAPA study also did several studies and there is no consensus which is the best test. Another problem is whether we should do the universal screening or we should do selective screening. What is this universal screening or selective screening? Selective screening is the one wherein we select a group of women who are at developing GDM. So this selective screening can be applied in populations where there is a low risk for GDM. Whereas universal screening or testing is done where the population with high prevalence of GDM. We know that 90% of the pregnant women have at least one risk factor or the other. India being Indian ethnicity itself is a risk factor. So in India, we always go for universal testing. The advantages of one step, there are two methods. One is one-step screening test, another one is two-step screening test. One-step screening test is a simple to follow and better patient compliance is there, easily diagnosis, and then it is more sensitive compared to the two-step. So there are, as I said, various bodies, WHO, ADS, PSG, and the ADA criteria. Everybody has recommended the universal screening except the two bodies. You come to the last line, just concentrate on the last line. DIPSI. What is DIPSI? Diabetes in Pregnancy Study Group of India. That is Indian for recommendations for Indian population. And this DIPSI recommendation is recommended by the FOXI also, and also the government of India. It's a one-step 75 grams glucose test. So the FIGO adopts and then encourages all its member associations to promote universal testing of all pregnant women for hyperglycemia in pregnancy. So how to diagnose diabetes in pregnancy? Again, we'll come back to the first thing. So diagnosis of diabetes in pregnancy should be based on one or more following results recorded by routine testing at any time during the course of pregnancy. At any time, if you do this test, the plasma glucose level more than 126 milligrams per deciliter, 2-hour plasma glucose level more than 200 milligrams after 75 grams of oral glucose load, or random plasma glucose of more than 200 with the presence of diabetic symptom, we diagnose is a overt diabetes This is not GDM. This is over diabetes in pregnancy. Whereas gestational diabetes, the diagnosis is made by using a single step 75 grams oral glucose tolerance test when one or more of the following results recorded during the routine testing, especially between 24 to 28 weeks of pregnancy or at any other time during pregnancy are met. The criteria are plasma blood glucose level between 92 and 125 milligrams per deciliter. We don't take 1 hour actually. 2 hour postprandial glucose load of 153 to 199 milligrams per deciliter. So if the fasting is between 92 and 125 and 2 hour post 75 grams glucose is between 153 and 199, we diagnose gestational diabetes. The previous one I said about the over diabetes. So the guidelines, as I said, DIPSI has given the guidelines way back in 2009, and we are all following the same thing. I think most of the obstetricians in India follow this. So when it should be done and whom it should be done? It should be done to all the pregnant women at the first booking. That means whenever they come for the diagnosis of pregnancy, you do the first test. Second, when if it comes negative, then you go for the second test, that is 24 to 28 weeks. So that values should be either 140 milligrams or between 140 and 199 milligrams, it indicates GDM. We don't consider the fasting plasma glucose because of so many reasons. The most important is antenatal women never come in the fasting state for checkup. If you ask them to come again, definitely there is a dropout rate. It's very high and patient will not come and he will lose the opportunity to diagnosis. And you should remember the fetal morbidity, diabetes is associated with the fetal and maternal morbidity and mortality. The fetal morbidity starts at not at 140, actually it is below 140 also. So HAPO study done, and actually India was not included in this study, so we don't follow HAPO study. So now the national guidelines has given 2018 recent guidelines. The government of India integrated GDM diagnosis and management within antenatal care package, as we do hemoglobin percentage, blood group and RH, and screen for HIV, HPSAG. So in the package, GDM also should be done. Screening for GDM is done. It's a recommendation by government of India. So recent guidelines, technical guidelines is testing of GDM is recommended twice during antenatal care. 2 times you have to do the testing. The first testing should be done during the first antenatal contact as early as possible in the pregnancy. Usually in our experience, we know women will come around 12 to 14 weeks. They will wait for 2 to 3 months and then only come to the doctor. So around we can take between 12 and 14 weeks, you should do the first test. If that test is negative, then only go for the second test at between 24 to 28 weeks. And there should be 4 weeks gap between these 2 tests. And this test should be conducted for all pregnant women, even if she comes late in for the antenatal care. We know in India, they come for the doctor checkup in the last few months of the pregnancy. Then also you can do this test. Don't wait for the 24 to 28 weeks. Same thing, if she presents beyond 28-week pregnancy also, only 1 test has to be done when she comes. So OGTT of all pregnant women should be done at Pradhan Mantri Suraksha Matritva Abhiyan sites as per the protocol. So how we are doing this test? A single step testing using 75 grams oral glucose, and we measure blood sugar after 2 hours. When a woman comes, we give 75 grams of glucose orally, dissolving that in 300 ml of water, whether the patient has come in a fasting state or non-fasting state, irrespective of the last meal, and then intake should be completed within 5 to 10 minutes. If she drinks fast also, there is a chances of vomiting will be there. So you should ask the patient to sip it slowly, but within 5 to 10 minutes. And after 2 hours, take the blood sample and do the blood sugar level with a standard glucometer, or you can use the venous blood with a GOD, POD method. If she vomits, imagine, if she vomits that glucose within 30 minutes, then you abandon the test and do the test next day. If she vomits after 30 minutes, you can continue the test, no change will be there. So you remember the number 140 milligrams equal to or more than that is the cutoff for GDM. If the blood sugar level comes as 140 milligrams, you consider that she has got GDM and the diagnosis is made and no other test is necessary. Coming back to again the algorithm, a pregnant woman comes, you do the GDM testing in the first antenatal visit, and if it is positive, manage as GDM. If it comes as negative, then repeat the test around 24 to 28 weeks. If it becomes positive, then treat her as a GDM. If it becomes negative, manage her as a normal antenatal pregnant woman. Once you diagnose GDM, then what next? What is the treatment or management? How do we manage diabetic pregnant woman? Remember, 90% of the pregnant women can be managed with diet. We call that as medical nutrition therapy. And we advise some simple exercises also. Doing a physical exercise will reduce the insulin requirement, and then glucose will be metabolized in the muscles. What is this medical nutrition therapy? We just make in such a way that we calculate the amount of calories she requires according to her body mass index, and that calories is divided into 3 major meals and 3 snacks. So this medical nutrition therapy we will advise for 2 weeks, and then after 2 weeks and again we do the blood sugar evaluation, that is fasting and postprandial. Our aim is to maintain the blood sugar level fasting between 80 and 90 milligrams, and then 2 hours postprandial between 110 and 120. This is our target blood sugar level, what we need. If you achieve this one after 2 weeks, you can continue the same medical nutrition therapy. If you don't achieve this medical nutrition therapy, the required values, then you should think the other managements like start oral anti-diabetic, it's OHS, and then or insulin therapy. Normally, we prefer the insulin because it controls the diabetes very well. But patient complaints also we should look into consideration. So we can try oral hypoglycemic agents as a first line of management. The oral hypoglycemic agents that are commonly used are metformin and glyburide. Metformin or insulin therapy is accepted medical management of pregnant women with GDM, which is not controlled with medical nutrition therapy. As I said, insulin is the first drug of choice, but patient compliance is more important. So patients will prefer oral hypoglycemic agents. So metformin can be started with 500 milligrams twice a day, and it can be increased up to 2 grams per day, and wait for the response. Start oral hypoglycemic agents, wait for 1 week, and then repeat fasting and postprandial blood sugar. If it is controlled, same dose can be continued. If it is not controlled, think of insulin. So insulin is required in high doses, and metformin also should be continued. So insulin therapy, the insulin that we are commonly using is a mixture of short acting and intermediate acting insulin in a ratio of 30:70. It's available as mixed. So we start this insulin therapy with 4 units if depending upon the blood sugar. Then if it is more than 200, start with 8 units. So how this insulin is given? It is given as a subcutaneous injection half an hour before breakfast. And then you should see to it that she takes her breakfast after 30 minutes. And as per you do this blood sugar, fasting blood sugar and postprandial blood sugar every third day, and then you adjust the insulin requirement. So the target value you should remember always the postprandial blood sugar should be equal to or less than 120. Fasting blood sugar, if it is more, that means she requires one more injection in the night. So morning pre-breakfast we give dose, and then at night pre-dinner 2 units of insulin can be given, so that will control the morning hyperglycemia. We also should think of hypoglycemia. What happens if the patient goes for hypoglycemia? That's why we are supposed to check the blood sugar levels quite often. We should know, I think the slides have changed that thing. Okay. What are the maternal complications of hyperglycemia, diabetic complications? Mother can have polyhydramnios, increased incidence of preeclampsia, then she has more prone for operative deliveries. Fetal complications include macrosomia and then neonatal complications. Where managing the antenatal management is more intensive, I think I say you have to carefully screen the fetal growth. Apart from the regular monitoring of the antenatal patient, we have to do the fetal echocardiography, because diabetes has got a tendency for cardiac malformations. At 26 weeks, you do the fetal echocardiography, and then at 34 to 36 weeks, you have to do the amniotic fluid volume and then the baby's weight, effective fetal weight. Then when to deliver, everything is normal. Okay, if everything is normal, then continue the pregnancy till 39 to 40 weeks. Don't allow the pregnancy to go beyond post-datism. If there are any problems complicating with the pregnancy, like preeclampsia, you have to think of delivering her early. Then mode of delivery. Operative delivery is indicated only for obstetric reasons. diabetes is not an indication for cesarean. Postnatally, baby has to be under the management of the pediatrician, because the baby is more prone for hypoglycemia, hyperbilirubinemia, and respiratory problems. And then you have to polycythemia also. So check the baby for the hypoglycemia. Every 1 hour, as the protocol says, baby born to infant born to diabetic mother, 1 hour, 2 hour, fourth hour, eighth hour, and then 12th hour, and then 24 hours after birth, the blood sugar has to be done. The blood sugar should be maintained. The neonatal blood sugar should be maintained beyond 40 milligrams. Then in the puerperium, actually, how to take care of the puerperium? Woman who requires insulin doesn't need any insulin immediately after the delivery. Most of the women doesn't require insulin or oral hypoglycemic agents. Do the regular monitoring of fasting and postprandial sugar, and then after 6 weeks follow up, you have to do a 75 grams oral glucose tolerance test. And then repeat this test after 6 months and then annually for lifelong. So we should know that the patient with diabetes in pregnancy has got more adverse outcome. So take home message here is all pregnant women has to be screened for diabetes. Then we usually follow the single step screening test, that is 75 grams glucose test, giving 75 grams glucose irrespective of the patient's fat state. Remember the number 140 milligrams, equal to or more than 140 is diabetes. Then 90% of the GDM patients can be managed with medical nutrition therapy. Deliver them at an appropriate time around 39 weeks. Postnatally, follow up the patient with GTT after 6 weeks, 6 months, and yearly for lifelong, because they are more prone to develop diabetes, type 2 diabetes within 5 years. As per the study, 50% of the women who had GDM will develop type 2 diabetes within 5 years. I think I have just told you the recent recommendations. Thank you very much. Thanks a lot. If there are any questions, I will take the questions. Thank you very much.
Thank you very much, sir, for your excellent and nice talk on GDM and its the management guidelines. And it's always an honor and learning to hear you, sir. Sir, if you allow me, then we'll take the questions from the delegates.
Please, sir, please, please.
So we have a first question. Whether putting on weight gain keep pregnant at risk for GDM? What is the ideal weight gain?
Sir, ideal weight gain according to the BMI, pre-pregnancy BMI, if she knows. Okay, on an average, if the BMI is normal, we allow 9 to 14 kg weight gain. If she is obese or overweight, we want her to be, the weight gain should be lessened. If she is obese, not more than 7 to 8 kgs of weight gain is allowed.
Okay, sir. Thank you very much, sir.
Thank you.
Sir, we have one more question. That is, when to do postnatal blood glucose testing?
Yeah, it's a good question. When the woman delivers, it depends upon, normally woman on medical nutrition therapy doesn't need anything. Okay, but still we do after 24 hours. No, need not be done immediately. But woman who is on insulin, that to high level of high doses of insulin, needs the fasting and postprandial should be done on the after 24 hours, and then depending upon that you start the insulin again. First 24 hours there is no requirement for any type of hypoglycemic agents.
Okay, sir. Thank you very much, sir. Sir, I don't find any additional questions from the delegates.
Okay, sir.
Sir, if any further questions from the delegates, we'll pass on to your mail ID.
Yeah,
So
yes,
that,
sir. Yes, sir.
yeah, you can reply them, sir.
Yes,
Sir,
sir.
it's always a pleasure and honor to have you, sir. And
Thank you, sir.
we look forward for your support for these educational initiatives.
Thank you,
And,
sir.
thank you, sir. Thank you very much for giving your valuable time.
Thank you, sir. Thank you.
Thank
Sir,
you.
Someshwar, sir.
Yeah,
Sir,
yeah, Patla.
sir, we would like to present one thing. Just our colleagues will present just 2 minutes.
Okay.